The focus of today's lecture is really going to be on the new guidelines for cholesterol management. A lot has changed in the past, I would say year and a half with respect to how we categorize patients as hyperlipidemic and then the treatment action plan that we put forward for them. So this lecture is actually going to differ quite a bit from the text because the text is the outdated recommendations and guidelines. So the textbook is good in terms of mechanism of action and side effects for the different classes of medications used in hyperlipidemia, but in terms of classifying patients based on their risk and then recommendations for what medications to use based on that risk are incorrect now in the textbook, but are correct in this PowerPoint and in the supplemental document that is uploaded to the readings for this week. So what is cholesterol? Cholesterol is a steroid. It's abundant in animal tissues and human tissues and is actually necessary for normal function. It helps the development and formation of cell membranes and some of the other hormones in our body. And cholesterol is primarily made in the liver. When there's an imbalance, however, for the amount of cholesterol made and the amount of cholesterol that our body needs to utilize is when we run into the issues of hyperlipidemia or dyslipidemias. So why do we worry about high cholesterol? We worry about high cholesterol because deaths from cardiovascular disease account for 36.3% of the 2.4 million deaths that occurred in the United States in 2004. So that's sort of an outdated figure, but what it leads you to see is that cardiovascular death that is caused by atherosclerosis is responsible for more deaths than cancer, accidents, chronic lung disease, and diabetes combined. So it is a massive quote-unquote killer when it's left sort of unchecked in patients in the community. Now, the role that cholesterol plays as well is that it's identified as a major modifiable risk factor in the following disease states: in coronary heart disease, in heart attack, and in stroke. So the major conventional risk factors for cardiovascular disease are an elevated LDL, a decreased HDL, people who smoke, people who have hypertension, either treated or untreated, patients with type 2 diabetes, although it probably spans a little bit into just type 1 diabetes and diabetes in general, patients of advancing age, and patients that have a family history of premature cardiovascular events. So if you had a first-degree relative, a brother, a sister, a mom, a dad who was less than 55 when they had a quote-unquote heart attack or event, or a female who was less than 65, that puts you at a higher risk for cardiovascular disease. So if we can control all of those modifiable risk factors, then we're really getting a handle on preventing premature cardiovascular disease or coronary heart disease. So cholesterol plays a big role in this, so it's important for us to kind of understand who we manage it in and how we manage it. So this is a pictorial of how a fatty or atherosclerotic plaque occludes various arteries. So the scientific definition of atherosclerosis is the process of fatty buildup in the inner lining of an artery, which is very beautifully illustrated in these pictures. So if LDL levels are high, and LDL is really the focus of bad cholesterol. That's the one that is the most detrimental when we're talking about coronary heart disease. So it's the one that we're going to target when we're treating people with hyperlipidemia. But if LDL levels are high, then cholesterol will deposit in the arterial walls, and that causes this atherosclerosis, or the buildup of the plaque within the artery. Atherosclerosis continues to cause the arteries to narrow as the fatty plaque builds on top of itself. That causes the artery itself to become weak and also to become less flexible. It becomes more rigid, so it's not as pliable when blood is flowing through it and when it's adapting to various changes in the body. That area of plaque can reduce the amount of both blood and oxygen that is delivered to vital organs, and it can rupture. When it ruptures, it causes a clot to form, and so that clot can then block blood flow, or it can break off and form an embolus. So you can have atherosclerotic plaque that breaks off and forms an embolus, or the fact that you've damaged the wall of the artery can actually cause bleeding in that area, and now we have a blood clot issue, which can also break off and cause an embolus. The formation of a thrombus or an embolus can cause angina if it affects the vasculature of our heart. It can lead to a myocardial infarction if it travels to the heart and actually causes death of the tissue by completely eliminating oxygen supply to that area. It can cause a stroke or a TIA if it travels to the central nervous system and the cerebral vasculature. And atherosclerosis, thrombi, or emboli can also contribute to cause and exacerbate peripheral vascular disease when we have these fatty plaque formations in the vasculature of the lower extremities. So it doesn't affect just one area. Atherosclerotic plaques are basically throughout the body. They can have negative effects, and they themselves are problematic, but then the complication of clot formation because of damage to the artery is a secondary complication as well. So cholesterol is one part of lipids, and triglycerides are another part of lipids. If we think of cholesterol, we should think of LDL, low-density lipoproteins. Those are bad cholesterol. And another thing I like to remind people is if you're trying to remember which levels are to be high, which levels are to be low, yes, LDL is bad cholesterol, but you want it to be low. That is good for the patient. HDL is high-density lipoproteins. That's good cholesterol, and we want them to be high levels. So we have HDL is happy cholesterol, LDL is lousy cholesterol. Triglycerides then are another part of the classification of lipids. LDL transports cholesterol from the liver to the peripheral tissues because we need to utilize it, for cell formation and for the production of hormones and various actions like that. HDL works conversely by taking cholesterol from the peripheral tissues and depositing it back to the liver for basically cleaning and excretion. So we need the balance of LDL and HDL in our bodies in order to prevent the swing of too much bad cholesterol taking additional and excessive cholesterol to the peripheral tissues. So before the new cholesterol guidelines came out, there were strict recommendations for what you do if somebody has an elevated LDL. Secondarily, the guidelines asked you to focus on triglyceride levels that were abnormal and HDL levels that were abnormally low. That is really not the focus of the new cholesterol guidelines that were published in 2014, I believe it was. These are included here basically just as an FYI. So these really aren't considered goals anymore, but they're still numbers that we should keep in mind if patients present to the clinic with changes in their lipid levels, because we can employ certain medications to positively affect these levels. So triglycerides, what we really want to think of here is that when they're less than 150, they're normal. When they're greater than 200, we're thinking that they're high. And when they're greater than 500, they're extremely high. And triglycerides at that level put a patient at risk for pancreatitis. So instead of thinking when and how do we treat triglycerides, we should think what's normal, what's abnormal, what is dangerously abnormal. On the other hand, HDL, because it's a happy or a good cholesterol, can actually remove a negative risk factor for a patient if it is of optimal or exceeds optimal levels. So sometimes you will notice that we focus on increasing somebody's HDL levels because of the positive net benefit that has in helping to decrease risk factors when we look at a patient's coronary heart disease risk. So the thing to remember here is less than 40 is low, and if you're at 60 or greater, that is an optimal HDL level. There are a variety of lipid disorders that can occur either as a primary event or a secondary event to an underlying disease. Primary dyslipidemias are associated with the overproduction or impaired removal of lipoproteins. So we're not clearing out the junky cholesterol. We're not using just the cholesterol we need for the primary functions, but there's an overproduction and a decreased clearance. The cause of primary dyslipidemia is usually not identified in most cases, and it actually plays an incredibly limited role when we're diagnosing and treating a patient. All we really care about is that they have a dyslipidemia that we can't attribute to any other cause. So we don't get into the nuances of splitting out all of the different types of dyslipidemias because across the board, treatment is the same. If you have elevated cholesterol, we're going to treat you based on the new guidelines. Disease states, though, that can contribute to dyslipidemias are diabetes, and hypothyroidism. So if we see somebody with elevated lipid levels and they have not been diagnosed with either of these two disease states yet, it might be worthwhile to test for those to see if it is a chicken or egg type of issue, and perhaps getting one or both under control will allow for the disease state to kind of go back to baseline and maybe need not as much medication therapy for management, but perhaps lifestyle modifications will suffice. Secondarily, we need to think about some medications that can alter lipid levels. Estrogens, thiazide diuretics, and anabolic steroids can all cause dyslipidemias. I don't know the true incidence of those medications causing dyslipidemias, but it is definitely food for thought and something to keep in mind if you're assessing patients who have a hyperlipidemia issue and medication therapy doesn't seem to be working as well as you had imagined it would. Perhaps a medication is causing your treatment to be less effective. So how do we screen for dyslipidemias? Well, a fasting lipoprotein profile should be obtained every 5 years in adults starting at the age of 20. And that speaks to the guidelines. Currently, the guidelines begin treatment at patients that are 21 years old. So potatoes, but 20 is a good number to start because it's easy for people to remember that every 5 years from the time they were 20, they need to get a fasting lipid profile. The fasting state is necessary in order to get an accurate assessment of the LDL and the triglyceride levels. When you consume food, these levels are naturally increased both by the food you're eating and by some different mechanisms within your body. So you will have falsely elevated levels and you won't be able to get a good assessment if the patient has not been fasting. That's typically 8 to 12 hours before the blood draw. More frequent monitoring may be necessary in patients that have significant risk factors for coronary heart disease. So we may test earlier in patients that have diabetes, patients that are hypertensive, both treated and untreated. Certainly you would test earlier in patients that had family members who had coronary heart disease at younger ages, because you want to try to eliminate this modifiable risk factor. This is a risk factor we can change. We can't change the fact that your dad had a heart attack when he was 55. We can't change the fact that you're old. We can't really change the fact if you have type 1 diabetes, but we can help change your dyslipidemia if we catch it early enough. So we're going to focus for a minute on clinical atherosclerotic cardiovascular disease. We're going to talk about this because the new guidelines use this as one of the major categories or ways to group patients into treatability, if you will. So coronary heart disease is defined as an acute coronary syndrome, a history of a myocardial infarction or heart attack, patients that have stable or unstable angina, and patients that have undergone coronary revascularization. So patients that have had cardiac stenting all fall into the coronary heart disease definition, which is part of the bigger definition of atherosclerotic cardiovascular disease. We also have to consider patients that may have had symptomatic carotid artery disease. So those are the arteries in your neck supplying your cerebral vascular system. That is classified as patients that have had a stroke or a transient ischemic attack. And then thirdly, clinical atherosclerotic cardiovascular disease takes into account patients that have peripheral arterial disease that is thought to be of an atherosclerotic origin, or patients that have had to have revascularization to the arteries in their lower extremities. So anytime something was occluded and caused decreased blood flow, that patient is at risk for cardiovascular disease, and they're going to be one of the major buckets of people that are treated based on the new lipid guidelines. So here's another pictorial of what we talked about earlier, that formation of the fatty plaque within the artery. This is sort of demonstrating how when that fatty plaque ruptures, which is the gross brown stuff coming out of the also gross yellow stuff, and behind it there is some blood. So as this plaque ruptures, the clot that forms because of that rupture gets bigger and blocks blood flow. Sometimes the clot completely blocks all the blood flow, and if that happens in the myocardium or the heart muscle, that portion of the myocardium starts to die and the patient has experienced a heart attack. So all of the tissues that are supplied by that artery that had that ruptured plaque and thus the formation of a clot begin to die below that blockage. So that's sort of the pictorial of how a heart attack happens when we're thinking of how does fatty plaque, how does high cholesterol cause a heart attack? The cholesterol itself isn't causing the heart attack, but the cholesterol plaque rupturing, causing a clot, the clot occluding the blood flow, is actually what causes the heart attack. Thus, if we can modify that gross yellow stuff in that artery and get rid of it, we've eliminated that risk for the clot formation. So in terms of the new guidelines, what are some of the changes? So the previous cholesterol guidelines, which were really in action for, gosh, almost 10 years, were called ATP3. And what they did is they used something called a Framingham risk score, which took into consideration all sorts of variables, all of those modifiable risk factors we talked about before, somebody's abdominal obesity or risk for metabolic syndrome, and they set up what that patient's LDL goal would be. What they did then is they classified, well, when do we start lifestyle treatments? At what LDL level do we tell people, hey, it's time to kick it into gear and change your diet and your exercise? And that was a different goal than the goal at which they considered drug therapy. And then there was a goal where they said, gosh, this LDL is so bad we have to put people on drug therapy. So there was a lot of tiny nuances to the ATP3 guidelines, which at the time worked very well. However, the Framingham score was based off of the Caucasian population, and we know now that different ethnic groups and different races do not respond the same way to risk factors, to medications, and to goals for therapy. So it didn't do a good job of generalizing or capturing the kind of culture and the makeup of the United States. It had secondary goals of treating triglyceride levels and then a tertiary goal of treating an HDL level. So what it did is it said, let's focus on LDL, but gosh, we really have to keep in mind triglycerides and HDL because all of these things together are all major contributors to atherosclerotic heart disease. And it even went so far as to say, if the triglycerides are really high, maybe that should be our focus first if the LDLs are only sort of elevated. So while at the time we thought it was very sort of directive and very useful, with the advent of these new guidelines, we see that there is much less variability to the treatment of hyperlipidemia, and our only and main focus really should be the LDL levels. So in 2013, the American College of Cardiologists and the American Heart Association, which often work together when we're thinking about cardiovascular issues, published the new guidelines. The new guidelines are more representative of the U.S. population of both Caucasians and African Americans. What it did is it estimated the time until the first hard atherosclerotic cardiovascular disease event. So it said, listen, we're going to classify people on how much time do they have until they have their first MI, their first stroke, or their first death that's attributed to one of these coronary heart disease causes. They don't have treatment goals anymore. They've developed a new risk assessment tool, and they identified 4 major groups that would benefit from cholesterol therapy with a statin. So they decided to come out and say, listen, we have looked at and assessed the clinical evidence that's out there. We think that all of these nuances that we used to worry about for cholesterol treatment are really just, white noise, kind of confusing the point that needs to be made that there are 4 groups that are going to benefit from a statin, and the statins are the go-to drugs and the cornerstones in lowering lipids to prevent cardiovascular disease. So the new risk assessment tool is actually something that's available online. It's searchable. If you type in 2013 lipid guidelines risk assessment, a number of calculators that look just like this will pop up. What this calculator does is it will, give me just a moment, I'm going to blow it up on my screen so I can read it better for you. It looks at what a patient's 10-year risk is for developing a coronary heart disease or an atherosclerotic disease risk. So it says, listen, we're going to calculate your risk. We're going to calculate your risk based on your gender, based on your current HDL level, whether or not you have diabetes, how old you are, what your total cholesterol is, if you are treated for hypertension, and what your systolic blood pressure is. And you can't see it on this screen, but your smoking status. Do you or do you not smoke? Then we can pick if you're Caucasian, African American, or another ethnicity. So when it pools all those things together, it says, listen, in 10 years, your risk for having a coronary heart disease event, so an MI, a stroke, or just straight up death from one of those issues, is 4.1%. We've calculated that over the next 10 years, there's a 4.1% chance that one of these issues will happen to you. If you change all of your risk factors. If you stop smoking, if you control your blood pressure, if you get your cholesterol in line, if you have good control of your diabetes, then we think that your risk will improve. Um, it also looks at your lifetime risk. So your lifetime risk, just as your situation is right now, is 50%. So sometime in your lifetime, maybe not in the next 10 years, maybe in the next 15 years, you're going to have a risk of a coronary heart disease event. But if you keep all of your risk factors in as tight of control and as great as you can, your risk is significantly decreased. So this is a really good way to help put a hard and fast number on something that a patient might be able to appreciate and understand. We did notice before that the new calculator better represents ethnic groups, but there's not a place where you can choose an ethnic group. So the research model is based on a better representation of the US population as a whole, but it's still just an estimate. So we're not getting down to the nitty-gritty of each and every ethnic group, but now at least we've expanded from just Caucasian patients to a little bit wider bucket. So how do we treat high cholesterol? The 2013 guidelines still have lifestyle modifications or therapeutic lifestyle changes, as they're referred to, as the foundation of good cholesterol management. It includes a heart-healthy diet, regular exercise, avoiding tobacco, and maintaining a healthy weight. However, that hasn't changed from the 2004 ATP3 guidelines, so they didn't go and revamp what was already working for people. Their focus was really a change on how we utilize statins and who we utilize statins in. In terms of cholesterol medications, they really focused on the fact that research does not support the utilization of non-statin therapies to decrease a patient's atherosclerotic cardiovascular disease risk. Maybe there's an added benefit there, but the research doesn't tell us that it gives us that much more bang for our buck, and so we really should be focusing on statin therapies. Because of the creation of these new guidelines, part of me thinks, and this is just totally Kate's opinion, that a lot of the extemporaneous, I'm going to call them, cholesterol medications will begin to fall by the wayside and may actually become extinct from our use because their role is so minimal in the end goal of preventing cardiovascular disease. So let's focus on statins. How do statins work? Statins decrease the body's production of cholesterol. Our body always wants to make cholesterol. Statins will do something called inhibit HMG-CoA reductase, which is an enzyme that converts a precursor of cholesterol to the end product of cholesterol that we utilize in our body. So this prevention of the synthesis of cholesterol in the liver lowers our LDL, or our bad cholesterol. Secondarily, statins can decrease triglycerides and have a small increase in HDL, but the workhorse of these agents is to decrease and lower the LDL, which is the primary issue in dyslipidemia. Here is just a listing of the generic and brand names of the various statins and whether or not a generic is available. There are only two agents that currently do not have a generic available, and that would be pitavastatin, which I don't see used in practice ever, and then rosuvastatin or Crestor, and that one might be nearing the end of its life of patent. So in the next couple of years, we might see Crestor come to market as a generic. So in the next couple of slides, we're going to look at what the four statin benefit groups are. There's a couple of different ways that I've organized them so that hopefully everyone's brain can kind of commit to memory who these groups are. So the new guidelines said that the atherosclerotic cardiovascular disease risk reduction clearly outweighed any risk of using statins in the following patient populations. Anybody that needs secondary prevention with clinical ASCVD. So that's that heart picture in the upper left-hand corner of this slide. If you had heart disease, we want to prevent secondary issues, so statin benefit outweighs any risk. If we move right to the left then, patients that are greater than 21 years old who have an LDL level that is at 190 or greater, scream, give me a statin, protect me now. So Previously, we had all sorts of weird cutoffs for LDL. At 160 and this age and this risk, we should consider treatment. At 190 and this age and this risk, we should consider treatment. Now they say, we're not worried about your LDL until you're older than 21 and it's greater than or equal to 190. Patients that are diabetics, either type 1 or type 2, who are 40 to 75 years old, who have an LDL between 70 and 189 should be on a statin. So that may seem like a little bit of a difficult population, but previously what we said is if you had diabetes and you weren't at an LDL less than 70, you need to be on a statin. Now we say, listen, your risk is really if you're between 40 and 75 years old. And just because you're a diabetic between 40 and 75 years old doesn't mean you have to be on a statin, but we're going to look at your LDL. And if you're between 70 and 189, which folks is a pretty big window, you should be on a statin. So basically what we did for the diabetic population is not say all diabetics need to be on a statin. We made a smaller window where we looked at the data and said the risk is greater in these folks. The last group then that will benefit from a statin are those patients that do not have diabetes but have an estimated 10-year risk of having an atherosclerotic cardiovascular disease event to be greater than or equal to 75%. Now, they also have to be 40 to 75 years old, and they have to have an LDL of 70 to 189. So basically, when somebody's 40 years old, we start, and when they're 21 years old, we look at them, and if they're greater than 190 in their LDL, we give them a statin. If not, we just watch them every 5 years. Once they reach the age of 40 years old, we look at them, and if they have diabetes, they've bought themselves a statin. If they don't have diabetes, but we look at all their other risk factors, and we assume that in 10 years they have a 7.5% risk of having an event, then we start them on a statin. So while me talking about it might be sort of hard for you guys to understand that these are actually better ways to classify our patients, trust me, they're better ways to classify our patients. There is less gobbledygook going on, and as you sit down and really look at this, I think you're going to be able to suss out in your mind what 4 patients you need to be paying attention to in your clinical practice. So this is just another way to think about the information that was in the last slide. We need to treat people that have clinical atherosclerotic cardiovascular disease, which if you will remember, those are people that have a history of an MI, people that have stable or unstable angina, people that have had to have coronary or other arterial revascularization, so perhaps they've had to have a carotid endarterectomy, which are the vessels leading up into your cerebral vascular system. Maybe they've had cardiac stenting, people that have had a stroke or a previous transient ischemic attack. These are all folks that fall under the clinical atherosclerotic cardiovascular disease definition. And then lastly, those folks that we think had an atherosclerotic originating peripheral artery disease problem in their lower extremities. The LDL greater than 190 group, and then our diabetes group, and our 10-year risk of greater than or equal to 7.5%. Okay, so we've said who we need to treat. Now what do we do? Now the focus really is on what kind of statin do I treat my patient with? And if you look across the board, a high intensity statin is what we are shooting for in these patient population. Gone are the days of wimpy 5 milligram doses of medications that sure, might reduce somebody's LDL, but they don't do it to an effect that we're going to see that's necessary in the coming slides in order to really confer that safety that the statin medication is meant to do. So high intensity statin, no other option in our first 2 classifications. Then we can look at patients with diabetes that fall into the correct age range and the correct LDL range, and we can say, listen, do we think that their risk is less than 7.5%? If so, they can get by with a moderate intensity statin. If we think they have a risk of greater than or equal to 7.5%, we have to have them on a high intensity statin. The last group might be a bit confusing for folks. Here it says, well, really you could use a moderate or a high intensity statin. The take-home point of this is that patients should always be on a high intensity statin unless they cannot tolerate that high intensity statin, be it for side effects, particularly referring here to muscle aches and pains. Perhaps they've had some LFT elevation, so changes in their liver function tests. Those folks should not be completely taken off the statin. We should take one step back and try them on a moderate intensity statin with the goal of hopefully titrating them back up to a high intensity statin. So this is a cool pictorial that helps us understand why the statin drugs are classified as low, moderate, and high intensity. In order to be a high intensity statin, that drug has to be able to decrease an LDL level by 50%. So if we look at the y-axis and we find the 50, and we follow that 50 across, there are very few dots that end up on the high side of that line. We see that rosuvastatin doses of 20% or 20 milligrams, and 40 milligrams, and then atorvastatin doses of 40 milligrams all the way up to 80 milligrams are really the only agents that are high intensity statins that guarantee a reduction of LDL levels of 50% or greater. So gone are the days of that very bottom red line of fluvastatin. Even pravastatin, which is Pravachol, is not giving us the bang for the buck that we need. Simvastatin, which is a very popular statin medication utilized in a lot of patients, doesn't reach the goal of high intensity definition. It does not reduce our LDL levels by 50%. There's argument that we take people off of their current statin and put them on a moderate or high intensity statin, but that's sort of left at the present time to the opinion of the provider. If somebody is at a good level of their LDL level, it has a good level of LDL, they're not still elevated, they're not still above 179 or 189, do we need to switch them? Probably not. But if we're not to goal yet, and we know that they're in one of those groups where a high intensity statin is a must, so the LDL greater than 190 or the clinical atherosclerotic cardiovascular disease, you better bet that we should start to move them towards a high intensity statin. So here's another way to look at that information about statin intensity. So if you got a high intensity statin, it lowers your LDL levels by at least 50%, if not greater. The products and their dosages are listed there. Moderate intensity statins, we have a lot more agents to pick from, and they're acceptable to use. So these will lower a patient's LDL by 30 to up to 50%. Atorvastatin at lower doses and Crestor or rosuvastatin at lower doses fall in this category, as do the higher doses of simvastatin and pravastatin. Now, I will caution you that while lovastatin, fluvastatin, and pitavastatin are all listed here, with the exception of lovastatin, the other two are really falling out of favor, and we're not seeing them utilized very much in clinical practice. Low-intensity statins should not even be something that's on our table anymore. We should not be considering these for patients because we're basically giving them a drug that has the propensity to cause some side effects, but we're not giving them the protection that they need to truly prevent the risk of atherosclerotic cardiovascular disease associated death. So low-dose simvastatin, low-dose lovastatin, and low-dose fluvastatin off the table, hence the big red X. So here's one way that we can look at a patient that comes into the clinic, and if we need to decide, how are we going to treat them. So a heart-healthy lifestyle is the foundation. So the diet, exercise, all of that jazz we really need to focus on. If your patient is greater than 20 years old and is a candidate for a statin, you would ask, do they have clinical atherosclerotic heart disease? And we say yes, and we say if they're less than 75, then we need to put them on a high-intensity statin. If they're older than 75, or if they're not a good candidate for a high-intensity statin, we got to put them on a moderate intensity statin. If we answer no to their clinical atherosclerotic cardiovascular disease, we say, well, is their LDL high? Yes, we put them on high intensity. No, then we say, well, are they a diabetic? And if they're a diabetic, do they fit those other parameters that we have? If we say yes, then we put them on a moderate intensity statin, unless we say, well, their 10-year risk for having an event is greater than 7.5%, in which case we put them on a high intensity statin. If we answer no to all of these questions, no, they don't have clinical atherosclerotic disease, no, they don't have a crazy elevated LDL, and no, they're not a diabetic with all those other modifiers, then we say, well, let's do primary prevention. They don't have diabetes, they have a good, an adequate LDL, and they're not receiving a statin right now. Let's estimate their risk again in 4 to 6 years. Remember, we're checking a fasting lipid level every 5 years, so 5 is the magic number, and at that time we will reassess and we'll put them through this loop of questions once again. So a lot of these slides are sort of repeating the same information, but we're looking at them in different ways so that each of you can find a way to help you understand and digest it the best. So this slide sort of outlines the things that we have to consider when we're thinking about using a high intensity statin for a patient. The overall goal of using a moderate intensity statin is really to prevent adverse effects or untoward outcomes. So there are some characteristics that will predispose an individual to a statin adverse effect. If a patient has multiple or serious comorbidities, including anything that has to do with renal dysfunction or impaired hepatic function. Patients that have a history of a previous statin intolerance or a previous muscle disorder should probably be trialed on a moderate intensity statin first and then titrated up to a high dose or a high intensity statin. Anybody that has an unexplained ALT elevation that is greater than 3 times the upper limit of normal will be predisposed to additional statin adverse effects, so they too might benefit from a moderate intensity statin. And then patients that are on certain medications, which we're going to talk about in a minute, that can sort of exacerbate issues that we see with statins. And anybody that's older than 75, we should probably exercise a little bit more caution on when we're thinking about high intensity statins. So how do we monitor patients once we start statin therapy? Well, we're going to want to get a baseline lipid level. That's obvious. We need to know what we're working towards. Then we will repeat that in 4 to 12 weeks. I'm going to tell you that most statin medications will exhibit a noticeable effect in LDL reduction at about 8 to 12 weeks. So 4 to 6 is kind of what the guidelines say, but 8 to 12 is a better picture of how effective our drug really is. We then repeat a lipid panel every 3 to 12 months as clinically indicated. So if this person is the tortoise or the hare and they're the tortoise getting to the goal, and remember, the goal is a 50% reduction in their LDL. So it's no longer a hard and fast number across the board. Everybody's LDL goal is going to be personal and individual now. Where did we start and what are we going to do to get to 50% reduction? So if we are slower getting to their 50% reduction, then we might want to check them more often to make sure that we don't have to kick them from a moderate to a high intensity statin. We will then compare their current cholesterol values to their baseline values. That helps us assess adherence of that patient's medication regimen, and it helps us determine if our current treatment is sufficient or if we need to kick it up a notch. We can consider decreasing a statin dose if 2 consecutive LDL levels are less than 40. So when ATP3, the 2004 guidelines came out, there was data that was coming out relatively frequently that said, keep driving those LDL levels lower and lower. Diabetics were being, sort of quote unquote forced into these LDL levels that were less than 80, then less than 70, then less than 40. And the question became, hold the phone, folks. How low is too low? We need some cholesterol in order to synthesize the cell membranes and the hormones and do some of the other functions within our body. So when do we know our LDL is too low? Well, for some reason, 40 seems to be the magical number. So if we are treating our patients in accordance of these new guidelines and we notice that their LDL levels are getting down in the region of 40 or less than 40, we can back off. We could decrease them from a high intensity statin to a moderate intensity statin and continue to monitor their LDL levels and go from there. So here is a pictorial that you can use in practice for monitoring. You get your fasting lipid panel. We're starting at the very top of this screen. In 4 to 12 weeks, did we get our anticipated response? If the answer is yes, then we reinforce them taking their medications regularly and we follow up with them in 3 to 12 months. If in 3 to 12 months we say, yep, we still got our response, we just keep reinforcing. If we did not get our anticipated therapeutic response, then we would reinforce the adherence. We may increase the statin intensity, or we could consider adding a non-statin drug. However, if you'll remember though, atherosclerotic cardiovascular disease risk is not majorly modified by adding a non-statin drug. So this should really be after we've done everything we can to optimize and ensure compliance with the statin therapy. If a patient is intolerant to a statin, we manage that intolerance. And the way we manage that intolerance is we try another statin. all statins are not created equal. Please remember that in clinical practice. If a patient has a poor response or does not like the adverse effects of Crestor, switch them over to atorvastatin, and vice versa. If necessary, go from a high intensity to a moderate intensity, working your way back up to a high intensity statin. The benefit of statins are so profound that a patient cannot be allowed to stop the use of a statin without significant clinical evidence that it is causing them harm. So, noted elevations in their LFTs, CK elevations, which is a measurement of muscle damage, that are incredibly high. So if a patient just doesn't like it or just doesn't like their muscle aches and pains, it's one of these things that we're going to have to tell them they need to forge ahead. If we really want to reduce your risk, this is where it's at, folks. The statin drug is life-saving in these situations. Side effect people are going to complain about when taking a statin drug is muscle pain or muscle weakness. At the present time, routine creatinine kinase or CK measurements are not necessary. I'm going to tell you this though, if you have that patient that complains about everything, or you suspect that that patient is going to have sort of a reaction to their statin, it's going to do you 1,000 times benefit to check a baseline CK on these folks, so that when they come in with the complaint of muscle aches and pains and you recheck their CK and it's a minor elevation or no elevation at all, you can put that patient's mind at ease that they are not in fact doing irreversible muscle damage, and that alone can be enough of a sort of motivator for the patient to continue taking this life-saving medication. Of course, you'll want to monitor their CK if they report muscle pain or weakness, but it's really hard to do anything with that number if you don't have a baseline to compare it to. Some people have naturally elevated CK levels. Sometimes it happens in marathon runners because of muscle breakdown during marathons. If people fall on the ground and are down for a long time, they'll have elevated CK levels. So while it is sensitive, meaning if it's elevated, we should suspect something, it's not specific. It doesn't tell us if it's elevated because of A, B, and C. So getting a baseline will save you lots of blood, sweat, and tears in your clinical practice, and is a really good number to show folks when they're complaining of muscle aches and pains, like, hey, listen, the benefit's still outweighing the risk for you here. Keep going. Routine ALT measurement is not necessary, so that's one of the liver function tests, but you should measure it if patients are complaining of unusual weakness, abdominal pain, or dark urine, because it's a marker of some liver damage. There is information out there that statin therapies can increase the risk for type 2 diabetes, but you'll see in the notes section of this slide that that risk is very, very minimal. With a moderate intensity statin, if we treat a patient for 1 year, 100 individuals were treated and the risk of diabetes was 0.1. So not even one case of diabetes with a moderate intensity statin. And that risk only went up to 0.3 cases when we treated patients with high intensity statins. So the risk of new onset diabetes for patients using statins really is only confined to those people that already had risk factors for diabetes. So I'm going to repeat myself a little bit here. If a patient develops mild to moderate muscle symptoms, you should stop the statin until the symptoms can be evaluated. So they're either going to be evaluated in the clinic if the patient can't get into you for a week, once you get a CK level, those types of things. They are not eliminated until all of the symptoms resolve, however, if you can pinpoint that they're not causing muscle damage, i.e. you can pinpoint that their CK is not insanely elevated. You will want to evaluate for other conditions that may also increase the risk for muscle symptoms, like hypothyroidism, patients that might have decreased renal or hepatic function, patients that have rheumatologic disorders that just happen to flare up or become sort of noticed at the same time they start a statin therapy. Patients that have vitamin D deficiencies can complain of achy legs and crampy legs, and patients that are overweight are going to have issues with muscle symptoms. You should resume the therapy if the muscle symptoms resolve, or if you've determined that another cause is contributing to those muscle symptoms. This is the interesting piece. I preached before that you should try a different statin, but what you need to do first is you need to resume the same statin in order to establish a causal relationship. So if you can't pinpoint an issue, there's nothing obvious that caused their risk for muscle symptoms, and their Crestor 20 milligrams was supposedly causing those muscle symptoms, after the washout period when their symptoms have resolved, restart Crestor at 20 milligrams and see if that same effect happens. Now, sometimes it will because in the mind of the patient it happened, but sometimes it won't, and that is a great encourager for the patient that they can continue to take their original medication. Here's my point again, that if the statin is the cause, stop the original statin and use a lower dose of a different statin. So if you started with a high intensity atorvastatin, perhaps you're going to move to a moderate intensity simvastatin as your secondary agent to try to avoid the muscle aches and pains. And then once that low dose is tolerated, you can gradually increase the dose with your goal to get back to a high intensity statin. So here are some general counseling pearls when you're talking to your patients about taking their statin medications. Patients should only take one statin medication at a time. Simvastatin, lovastatin, and fluvastatin are best taken in the evening, and the reason is because their half-life or duration of action works in a short period of time, and the majority of our cholesterol is synthesized overnight. Now, you'll recall that I've told you in other lectures that I am less worried about a patient taking the medication at night. I am more worried about them taking it at all. So if a patient tells me there is absolutely no way they'll remember to take an evening medication, then I don't care. I'd rather they take it in the morning. They'll still get the benefit of decreasing the synthesis of cholesterol in their body. There is some information out there that grapefruit juice can cause issues with statin medications, and while it does inhibit intestinal enzymes which metabolize some of the statins, most patients can safely have a half of a grapefruit or 8 ounces of grapefruit juice daily. One of the things here is that consistency is key. So if patients have always been drinking grapefruit juice, sort of like with respect to our vitamin K consumption with warfarin, if they've always been doing it and they keep doing it, well then we're going to get them the right dose of statin to give them their maximal benefit. If they, binge on grapefruit every once in a while, that's when they run the risk of making their medication less effective. We want to stress that adhering to statin therapy is important because you cannot feel when your cholesterol is elevated. You can't tell that you're forming atherosclerotic fatty plaques in your arteries, and so taking your drug every single day is incredibly important in order to get the maximal benefit. All statins are pregnancy category X, and they should be avoided in breastfeeding. So, to reiterate, the new guidelines say that there is no evidence to support the use of non-statin cholesterol-lowering drugs. If we want to use non-statin drugs, we should be using them combined with statins, perhaps for an added benefit, or in the case where a patient has a very low HDL and we need to get that up in order to remove one of their risk factors, or an incredibly high triglyceride therapy such that they're at risk for pancreatitis. The other time it might be acceptable to use a non-statin cholesterol drug is when you've exhausted all the statin possibilities and you have a truly statin intolerant patient. Now, with that being said, they're not going to be afforded the same protection that the patients taking the statin drugs are afforded. The guidelines do not provide an overview, of the non-statin medications or their safety profiles. We're going to cover that here in the next couple of slides just for completeness sake, but they do not really provide recommendations. So they tell you these are the non-statin drugs, and these are their safety profiles, but they're not going to tell you we prefer this over this, or secondarily you should add agent A and then agent B. So they still give you some information about them, but they don't make any recommendation claims. The 2013 guidelines do stress the adherence to lifestyle modifications and to statin therapy before you do anything else. So before you add a non-statin drug, make sure people are not smoking, managing their weight, eating a healthy diet, getting physical activity, and taking their statin. The data, there's no data available and there's no recommendations for treatment in patients that are older than 75. So this has been an argument for a long time. If you remember our category of people without atherosclerotic cardiovascular disease, we said, well, what's their 10-year risk? So what we're trying to do is we're trying to modify the risk that they die from an atherosclerotic cardiovascular event in the next 10 years. If you're 75, Are we that worried about you dying from something in the next 10 years? This sounds very morbid. It's not supposed to. We're not. Maybe we think that the risk of statin therapy, which there is risk with statin therapy, there's potential liver damage, which is called hepatotoxicity. There's that risk for muscle aches and pains. Maybe the risk in patients that are older than 75 outweighs the benefit. Unless they have clinical atherosclerotic cardiovascular disease, then we know that their risk factors for the event are so great that the statin therapy risk is outweighed by the benefit of the drug. But if you have this cute little old lady who's 78 years old and you notice for the first time that her LDL is creeping up a little bit, well, something's going to be the end of that story. And do we really want to add a statin therapy that might just cause more angst than it does benefit? Now, we don't necessarily take people off of their statin therapies once they reach 75 years of age and older, particularly if they're, event or symptom free from them. But there is that fine line of when do we start folks? Do we have to start folks on them in advanced age? There's a wonderful example in the hospital when we had an 80-year-old lady who was, relatively vivacious and, living on her own and doing pretty well. And at 80 years old, she had a stroke. And so the guidelines would tell us she had a stroke, she should be on a statin therapy. Yeah, but she's 80. Do we need to add a statin therapy? And so we had a conversation with the patient and we talked to her about risk in the next 10 years. And we were very frank that, statins are not necessarily dangerous, but they're not the safest drugs on the market for somebody that's 80 and tiny with not the best kidney function. And she said, you know what? C'est la vie, something's going to happen one day, I'm fine not taking a statin. So there are such certain situations where you're going to have the conversation with the patient or the patient's caregivers to decide, do we really need to do that? And then also there's not a lot of good data out there about treating hyperlipidemia in patients that need hemodialysis. So basically they're not saying you shouldn't do it, they're just saying that there are not hard and fast rules that tell us if we should or if we shouldn't. So the old adage of the ATP3 guidelines of treat to a target and lower is best is no longer advocated. There is no evidence right now to support treating to a specific LDL goal, or what's also referred to as a non-HDL goal. Right now, we need to just anticipate that we're going to get a therapeutic response and we're going to decrease a patient's risk if we can get their baseline, if we can decrease from their baseline LDL to 50% if they're taking a high intensity statin and anywhere from 30 to 50% if they're taking a moderate intensity statin. So the take-home message is that LDL goals are now each individual patient specific. There's not an overarching goal anymore. Reduce 50% from what you came to me at. For completeness sake, we are going to review the other classes of cholesterol medications, the bile acid sequestrants, which are cholestyramine, which is called Questran, and Cholselvaman, which is Welchol. Those are probably the two I see most often. The fenofibrate medications, Tricor, Lofibra, and Triglide are fenofibrate. Trilipics, which is fenofibric acid, and then Lopid. Lopid is one a lot of folks know about. That is gemfibrozil. And then niacin examples. So this is nicotinic acid, which is either immediate release or slow release niacin, and then niaspan ER, which is an extended release niacin. Both the fenofibrates and niacin have good effects on triglycerides and increasing HDL levels. But please remember that research does not support the utilization of these to decrease somebody's risk. There's a lot of uncertainty about exactly how fenofibrates work when we're talking about hyperlipidemia. We know that they increase the catabolism of VLDL, and when we do that, we decrease triglycerides. So that's how they help decrease triglycerides. And additionally, triglyceride synthesis is decreased because fenofibrates suppress the lipolysis of in adipose tissue. Secondarily, fenofibrates can increase HDL, and I believe they do that by decreasing the clearance of HDL, although to be honest with you, I'm not 100% sure. Side effects of fenofibrates are GI complaints like nausea and diarrhea. Patients can complain of rash, dizziness, or hepatotoxicity. It's important for us to keep in mind that fenofibrates can also cause muscle aches and pains, and so particularly when we use gemfibrozil in combination with a statin medication, we further increase the risk for that muscle ache and pain referred to as myopathy. It's important to note that fenofibrates really have a variable and minimal effect on LDL levels. So this is not something that we're adding to get that LDL closer to that goal of a 50% reduction. We're targeting triglycerides and HDLs with this medication. So one of the fenofibrates was fenofibrate. And fenofibrate is actually a prodrug that is converted to its active metabolite, fenofibric acid. So fenofibric acid itself, that active metabolite, inhibits the triglyceride synthesis and accelerates the removal of the lipoproteins. And if you need to use an agent in combination with a statin, fenofibrate is where it's at. That's the preferred agent. Niacin works then by inhibiting free fatty acid release from the adipose tissue, so that's the definition of lipolysis, which leads to decreased LDL. It also works to increase the HDL, or our good quote-unquote happy cholesterol, by delaying the HDL clearance. The most commonly reported side effect of niacin is flushing or itching, so that overwhelming sort of heated red feeling of the face. We can educate patients how to avoid this side effect, and that involves taking an aspirin, and even a baby aspirin is sufficient. They should take it about 30 minutes prior to the niacin dose. They should avoid hot showers near the time of their niacin dosing, and they should avoid hot beverages near the time of their niacin dosing. Those are proven things that will help decrease the side effect of flushing. Additionally, this is a side effect that should wane over time, so patients should develop a tolerance to it. Secondarily, using the extended release formulations of niacin will help further avoid this side effect of flushing. There are some GI complaints with niacin, nausea, diarrhea, and some kind of heartburn or indigestion. It is possible for hepatotoxicity to occur with niacin, and really, because niacin, fenofibrates, and statins can all cause hepatotoxicity, the risk for that would obviously be additive if we're using these agents in combination. We should really think of niacin as the go-to med if we want to increase somebody's HDL level, and it's also a wonderful drug if we need to get somebody's triglyceride levels down. And really, we're only focusing on decreasing somebody's triglyceride levels when they're getting to that abnormally high level of the around 400 to 500 or greater, because we're worried about a patient's risk for pancreatitis at that level. So another interesting fact is that nicotinic acid, or niacin, is thought to be effective at increasing somebody's HDL, even when that's their only abnormal value in their lipid panel. So sometimes if they're otherwise normal, we might give them some niacin just to bring their HDL up, because that helps remove one of their negative risk factors for atherosclerotic cardiovascular disease. Clinical trial data also suggests that women may have a greater response to niacin than men do. Just food for thought, or if you're ever on Jeopardy! Finally, bile acid sequestrants are cholesterol medications that are unique because they are not systemically absorbed. They bind to the bile acids that are in the intestinal lumen. There they form insoluble complexes and produce a large increase in the fecal excretion of the bile acids. So we don't have the bile acids going to the liver to be synthesized into cholesterol. Instead, we sort of trap them and excrete them. We do have to be cautious in using bile acid sequestrants with other medications, because they will interfere with the absorption of those medications. Because they create almost a protective coating in the stomach to prevent absorption of the bile acids, they can also prevent absorption of medications. These agents are not very well tolerated by patients, and it's basically because they have a lot of GI side effects: constipation, bloating, nausea, and they're also in very non-palatable dosage forms. Many times they come as powders, which patients would prefer to not take. One of the products, I want to say it's Well-Call, comes as a tablet. So sometimes patients will preferentially pick that over, for example, the Questran or Questran Light, which has fewer carbohydrates per packet. Those are powdered formulations of bile acid sequestrants. These really don't have a ton of efficacy in decreasing any of our lipid levels, but there is a bit of an additive effect for LDL decrease when we use this in combination with another agent. So that wraps up some of the additional medications that we see in treatment of hyperlipidemia, recalling that statins are the #1 drug we should be thinking about and trialing in all of our patients. You'll notice from your text that there was one other medication, ezetimibe or Zetia, that I did not cover, and that's because that's really losing a lot of popularity in the world of hyperlipidemia treatment. When it came to market, people thought that it was going to be fantastic because it had this interesting mechanism where it worked on the brush border of the intestines to help limit the amount of cholesterol that was absorbed from a person's diet. In theory, that doesn't play a huge role into dyslipidemias, and so you're adding this medication, potentially adding some side effects, but not really getting a whole lot of additional reduction in LDL levels. So we don't cover it here. You might still see it in combination with simvastatin. That brand name is Vytorin, but it's not a medication that is typically prescribed to patients any longer. And hopefully, as you continue in your clinical rotation hours, and then as you transition into practice on a nurse practitioner on your own, you will see the shift that will be made towards targeting patients in the groups that we talked about today to get their LDL levels to 50% of their baseline. So I don't think that this week you're going to suddenly start to see your practitioners all practicing in this new model of lowering lipid levels, but over the course of the next couple of years, that will be the new norm of how we treat patients with elevated lipid levels. The quiz will be open until April. I think I'm going to keep it open until that Friday before Easter. So that would be April 4th, 3rd or 4th, I believe. So go ahead and attempt the quiz, see how well you do after this lecture, and we look forward to reading the group's objectives when they complete them. So thanks very much, gang.